Welcome to What Matters, Princeton Foundation for Peace and Learning's brand new video series. In this series of interviews and panel discussions, we discuss various social issues and solutions thereof with the global experts in fields of women empowerment, education, healthcare, and world peace. In today's episode, we'll feature a panel discussion between Professor Randeep Guleria, Dr. Soumya Swaminathan, and Dr. Tom Inglesby. Professor Randeep Guleria currently serves as the president of AIIMS Bilaspur. Previously, he was the director of the AIIMS New Delhi Center. Established in 1956 by the Government of India, AIIMS is the apex medical research institute of India and is rated as one of the top medical institutes in the entire world. Professor Guleria has been an advisor to several international organizations, including the Center for Disease Control in the US, the World Health Organization's SAGE group in Geneva, the International Atomic Energy Agency in Vienna, and the European Commission. He's been a member of several committees in the Government of India, including the Joint Monitoring Committee to monitor outbreaks of pandemics. He has authored more than 400 scientific papers. During the pandemic, Professor Guleria co-authored a book, Till We Win, India's Fight Against the COVID-19 Pandemic. This book discusses why pandemics happen, the Indian response to pandemics before and during lockdown and the unlocked periods, and key learnings for health sectors during these periods. Professor Guleria is the chairman of the Princeton Foundation India Board of Advisors and is guiding the development of our global multidisciplinary healthcare strategy, effectively bringing together government, non-governmental, and professional organizations. Dr. Soumya Swaminathan recently served as the Chief Scientist and the Deputy Director General for Programs at the World Health Organization. Dr. Swaminathan was Secretary to the Government of India for Health Research and Director General of the Indian Council of Medical Research from 2015 to 2017. Before that, Dr. Swaminathan served as coordinator of the UNICEF/UNDP/World Bank/WHO Special Program for Research and Training in Tropical Diseases in Geneva. Dr. Swaminathan is currently serving as the Principal Advisor to the Union Ministry of Health and Family Welfare for the National Tuberculosis Elimination Program in India. And finally, we have Dr. Tom Inglesby. He is the Director of the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health. He is also a professor in the Department of Environmental Health and Engineering in the Johns Hopkins Bloomberg School of Public Health, with a joint appointment in the Johns Hopkins School of Medicine. Professor Inglesby currently serves as chair of the Health Security Interface Technical Advisory Group at the World Health Organization. Previously, he served as senior advisor on the White House COVID-19 response team and was the White House National Coordinator for COVID. He has also served on the Biden-Harris transition team on pandemic policies. Dr. Inglesby has published more than 170 scientific papers and is the editor-in-chief of the peer-reviewed journal Health Security. In 2023, he was elected to the National Academy of Medicine in US.
Okay, thank you, Ameya, and welcome our distinguished panelists, Professor Guleria, Professor Inglesby, and Dr. Swaminathan. We really appreciate the time you spared to discuss this very important topic of global healthcare to strengthen the healthcare systems across the globe. You know it quite well based on your own experience that pandemics, the whole world went through the COVID pandemic, and you all know very well that pandemics are not random events. They are happening they happen on a regular frequency, and the frequency is somewhat increasing now because of the global travel and other reasons. And in the last 20 years, there have been several publications which clearly warned about the happening of a pandemic like COVID. But somehow, some of these or most of these scientific publications were ignored. So here we are now trying to understand what we have learned from the COVID pandemic, how we can be better prepared for these emergency situations, and in general, how we can be delivered a better healthcare to the population and community at large across the world. So that's the purpose of this panel discussion. Uh, I will start with Professor Dr. Swaminathan, ma'am. So, ma'am, based on your experience working at WHO, uh, uh, could you please share with us what are the advantages and disadvantages of global collaboration in healthcare? What are the key barriers to the global healthcare collaboration and how they can be overcome?
Thank you very much, Ashutosh ji, for this panel discussion and also for this question. Let me start by saying that I cannot think of any disadvantages to global collaboration in healthcare. I can only think of advantages, but there are barriers. So if we take the example of COVID itself, and from the vantage point of the WHO and being the chief scientist at that time, what I really was very fortunate to witness was the scale of global collaboration that happened among scientists, regardless of which country they were from, which discipline. I mean, we all know that people dropped what they were doing and turned their attention to COVID and tried to use their skills to somehow help advance our knowledge and understanding so that we could find the right tools to come out of the really bad stage of the pandemic. And so that's the reason why we were able to develop vaccines within 1 year, why we were able to develop many different types of diagnostic tests, including very simple rapid diagnostic tests. And we understood so much about the virus, about immunology, about epidemiology, about transmission. I think it was unprecedented. I don't think for any other disease or even infectious or other types of diseases that we've had in such a short span so much scientific work, so many publications, and such a deep understanding, which enabled us to overcome the pandemic as a global community. So it was, and WHO was involved in many of these coordinating activities. We had hundreds of expert groups, literally, meetings from morning till night, of course, running on online platforms. And we were able to therefore not only collect all of these advances that were happening in real time, but we were also then able to use that to put out guidance to countries and update it regularly as and when we got new. And a good example is the variants of COVID that we started seeing. Some of them turned out to be variants which were not so important, so they were not called variants of concern, but others which had properties of greater transmission or a more severe disease pathology. We call them variants of concern, and the world got very good at sequencing, at identifying changes, at sharing data on publicly available platforms, on analyzing, on correlating with clinical and epidemiological data, and essentially coming to more or less the right conclusions about which variant was behaving in what particular way. So this was a very good example, I think, of collaboration, data sharing, and doing away with the usual scientific barriers like I want to publish my paper and therefore I'm going to hold back my data. There was none of that. And all journals also accepted publications where the data had already been put out in the public domain. Everyone cooperated, from ministries to science agencies to regulatory agencies to journals and so on. But I would just like to add that there was an issue where global collaboration did not work, and that was in the sharing of some of these tools, resources, countermeasures, as we call them, despite the fact that we had anticipated that there would be some inequities in sharing. We had tried to come up with solutions like COVAX, for example, for equitable distribution of vaccines. But despite all that, we did face, if you remember in 2021, a situation where some countries in the world had access to vaccines. They were already vaccinating their populations, old, middle-aged, young. There were others who were waiting in the queue for a very long time without being able to vaccinate even their elderly and their healthcare providers. That led to a lot of unnecessary loss of lives And so I think as a global community, we did not do well when it came to sharing of the fruits of the science. We did well at sharing, basic knowledge and so on. But when it came to products, unfortunately, we did not do so well. That's a lesson that we need to learn for the future.
Thank you, ma'am. Thank you so much for sharing your experiences at WHO at the global level. That was very helpful. Next, I would like to turn towards Professor Inglesby. Professor Inglesby, what were as you were leading some efforts in US about the counter measures for the COVID, so what were the key lessons learned from the COVID in US healthcare system? How can US help strengthen the healthcare system of other countries? And what are some successful examples of global healthcare collaboration? What we can learn from those collaborations and examples?
Great. Well, thank you so much, Ashutosh, for having me on this panel. Thank you to the Princeton Foundation, and it's great to be with such esteemed colleagues, Randeep, Soumya, to talk about these important issues. So thank you. Your first question about lessons from the COVID from the U.S. perspective, so many lessons, but I'll just focus on two. The first is that, to reference Soumya's point, and it was incredibly important to develop new tools to respond to COVID. And U.S. and of course India did a lot of that. Vaccines, medicines, diagnostic, personal protective equipment, and what many lessons about that development process, which maybe we can come back to. But I think turning to something that was a little bit less apparent, not only did we need to develop those tools in the US, but we also had to find ways to pay for their manufacture and distribution, and we had to implement the distribution pathways. And I think we had paid some attention to that before the pandemic, but it turned out that those were huge challenges for us in the United States. We had some emergency funding from Congress, but it wasn't nearly enough to pay in the US system for all of the tools that needed to be used for all of the people. And so we had to rely on our private health insurance programs and our government health insurance programs and create new programs to pay for the uninsured and the underinsured in the United States to be able to access some of these tools. And so that was a big, complex, rapid process of trying to understand how we were going to pay for all of those things and cover the people who were most at risk in the United States or least able to access healthcare. And the second was that we had to find ways to distribute all of these very kind of life-saving tools or prevention tools across the country. And so we used hospitals and clinics, but they were not nearly enough to reach people in hard-to-reach places. So we ended up using pharmacies and schools and prisons and nursing homes and finding places, like many countries, all countries probably, we had to use all of the distribution systems that we had, plus create new ones. And I think we'll have to bring that into future planning efforts, kind of reliance on distribution systems and implementation programs that we didn't necessarily plan for or expect in our planning ahead of time. So those interventions were really important. Hopefully we'll take those forward. A lot of innovations around distribution, such as the use of the U.S. postal system to distribute tests to every household in America that wanted them. They just had to click a button on the web. That was something very new for the United States to be able to do that. And we did see that COVID took advantage of all the pre-existing inequities in our healthcare system. People who were already at a disadvantage face a lot of trouble accessing either these tools or care at times during COVID. A second quick lesson which we all dealt with was the problem of misinformation. It was a very serious problem in the United States. It still is, of course, on many issues. But during COVID, lots of misinformation about the impact of the disease, the severity of the disease, the safety of the vaccine, the utility of the vaccine. And many, many people lost their lives because of the misinformation that was spread. It's still something we struggle with. There are lots of new efforts to try to pre-bunk bad information, whether it's misinformation or disinformation, as well as kind of debunk it once it's out there. A lot of recognition that we need more web literacy. We need people to be able to discern real from fake information, but still a huge amount of work to do. And then to your second question, and then I'll turn it back to you. Your question about how does the U.S. work to strengthen healthcare systems globally? And that's probably, it's a big conversation. There have been many different kinds of approaches that have been pursued. In general, either through the U.S. either works bilaterally with one country at a time to focus on specific things, or it does like to work through multilateral health institutions and contribute to those programs where it can. Things like or organizations as important as the World Health Organization, of course, and other organizations, international organizations like Gavi or Yavi or UNICEF or the Global Polio Eradication Initiative. And the U.S. kind of pursues different ways of interventions, either as a donor or an operator or a research institution trying to support research initiatives or technical assistance. There's a variety of ways that the U.S. tries to do that work, and I'm happy to go back to specific examples of programs later in the discussion if that'd be useful. But thanks for the question.
Thank you so much, Dr. Inglesby. That was a very good overview of the situation and what happened during the COVID. Now turning towards Professor Guleria, sir, the same question to you, and based on the experiences, you all will concur that it is not a one-way street. It's not just that US can help India or other countries. US can also learn a lot from the experiences or the diseases or the management system or healthcare delivery system in these countries. So same question to you, Dr. Guleria, sir, that what were the key lessons learned from COVID in India, in Indian healthcare system? How India can help strengthen the healthcare system of other nations, including US? And what are some successful examples of global healthcare collaborations and learning from those collaborations?
For inviting me, and thank the Princeton Foundation for organizing this webinar. All of us learned a lot during the pandemic, and I think it's still a learning process for all of us. But what we learned in India, and I think the key lessons were, I think the lessons, some of them were good, some of them were bad. But I think a lot of good lessons that we learned in India was that there was a lot of alignment first between the entire system. So whether it be the political system, the bureaucratic system, the scientists, or even those who had to deliver goods at ground level, the ASHA workers, there was a very good understanding between all of them. And that alignment helped in really getting messages through, getting things done, which I think was something remarkable as far as India was concerned, that everyone was supporting each other. The Prime Minister's office formed a number of high-powered committees which really aligned and tried to do whatever was possible during the pandemic. And that really was something that was unique as far as India was concerned. I know this was a challenge in many other countries because of a lot of misinformation, but this was something that I think we learned a lot. And because of that, when the Prime Minister announced the lockdown, there was a total support of that lockdown, and that bought us some time to really prepare in terms of creating COVID centers, COVID hospitals, and trying to really build as far as the equipment and the infrastructure was needed. There was also a lot of push by the government, and despite limited resources, a huge amount of money was put aside by the cabinet initially for vaccine manufacturing and for testing. And testing was initially done free by the government itself. Private institutes private labs were also rolled in, and the price was kept at a certain limited. It was not allowed to be increased, so that people who got testing done did not have to pay a very heavy amount. But I think what was also done was there was also a lot of scientific involvement. And in the early part, a lot of the RT-PCR testing reagents actually were coming from outside. But subsequently, NIV Pune developed its own testing kits, and that really brought down the price as far as testing in India was concerned. And the same happened once we had the rapid antigen testing kit that it was possible to manufacture it in India, and that really helped a lot. The other lesson that I think we learned was that you have to have a local resilience, especially when you are in a country where you are relying on resources from other parts of the world. I'll give you an example of PPEs. PPEs in India used to come basically from China. during the pandemic, we were having a time when we felt we may have shortage of N95 masks and PPEs because they were all being imported. And I remember at one of the meetings that we had at the All Institute of Medical Sciences, we did a project as whether we could recycle PPEs. If you had a personal protection equipment which was not soiled, which was not torn, you could actually disinfect it and make sure it was again free from the virus and reuse it, because there was this whole concern about shortage of PPEs. But again, a lot of manufacturers in our country got together, and we actually started making PPEs in our own country, N95 masks, and there was a surplus of these things which we were able to export subsequently. Then the same issue is, I think, as far as the vaccine is concerned. I remember when we had the H1N1 pandemic in 2009, although India was manufacturing vaccine, we didn't have the R&D to make our own vaccine, and we had to rely on support from the WHO for vaccines during the H1N1 pandemic. And by the time the vaccines came, the pandemic had moved quite ahead, and there was very little uptake for vaccines. This time, I think from the very beginning, there was involvement by scientists, support by the government and by the private sector, and we were able to manufacture vaccines in less than 1 year, not only one, but two vaccines. One was, of course, the AstraZeneca vaccine, and the other, the vaccine by Bharat Biotech, which was also made as Covaxin. But this also gave a boost to research for vaccine development. And in the next 1 to 2 years, India was having multiple platforms for vaccine development. We had an mRNA vaccine, we had a DNA vaccine, from Zydus Cadila. We had a viral-like particle, VLP particle vaccine. So I think we, at the end, had almost 5 or 6 vaccine platforms which were made in-house in our own country. And that gave us a lot of confidence that if there was subsequent outbreaks, we would have the capacity to make vaccines from different platforms in our own country. The other challenge was that because the virus was mutating very rapidly, we needed to have good genomic surveillance to look for mutation. And that was something that the government did in setting up a network known as INSAGOG to look for the mutations that were happening and to pick them up early. But one of the downsides in the lesson that we learned was, although we had the data, there was lack of collaboration between different labs, I would say. They were working a little bit in silos, and therefore the clinical epidemiological link was not there. So I would say that early in 2021, the NIV and the NCDC picked up the variant which was known as that time the double mutant, which was actually the Delta variant. But they were not able to link it with the fact that this is going to cause severe pneumonia, will lead to a high mortality. And that actually we did not have a warning well in time, and that's why we had huge number of cases and mortality during the second wave. So I think what is important is, if you have a good surveillance network, you must be able to link it with the epidemiological and the clinical data that is also available in different setups, so that you can really link the variants of concern that are coming up to what they are causing and how you can be prepared for whatever event happens subsequently. This is, I think, one lesson that we learned, or I learned as a matter of fact, that we need to have more collaboration between clinicians, between scientists, between various research institutes, so that the data sharing is strong and we can really move forward in terms of acting real time rather than retrospectively when the virus has already caused an effect. So I think that was the other important thing. The other lesson that we learned, and that I think is something which is very important, because Indian healthcare system has two broad arms. One is the public sector, which is run by the government and which is the backbone as far as rural India and tier 2, tier 3 cities are concerned, and the private sector, which is run by insurance or out-of-pocket expenditure. During the pandemic, initially the burden of the managing patients came into the public sector, and there was a huge surge of patients, and a lot of public sector hospitals had a huge amount of patients. This led to two things. One is resource limited facilities, because we did not have enough beds. And secondly, there was a neglect as far as non-COVID illnesses were concerned. So during that time, the TB program, various other infections, immunization, all of that suffered a lot because the focus was predominantly on COVID, and we were not looking that much on non-COVID illnesses, which was still there. So I think that is another important lesson that we've learned, that we need to have a plan in place which looks at both pandemic management, but make sure that at that time other diseases are not neglected, because they are equally important, whether it be malignancies. I know many patients who had cancers did not get treatment on time, and it led to more advanced disease, which was associated with higher mortality. So that is the other lesson, that as a clinician, I felt we should have developed strategies both for COVID, but also for non-COVID care, so that that did not suffer. And then subsequently, there was a lot of push by the government and the public, the private sector hospitals also came onto the management of COVID-19. And that really helped a lot, because when we had the Delta wave, the support by the private sector along with the government sector helped in actually providing a larger number of beds and better quality care. So I think it's very, very important for us to really try and develop a strategy where all parts of the healthcare system, whether it be the private sector or the public sector, move in unison, move together, so that they can provide the best quality of care. And we must have a plan which looks at how can we really increase our resources when there is a surge in the number of cases without affecting the usual patient care that comes as far as non-COVID or non-pandemic cases are concerned. So these are the lessons that I've learned. And I think one good thing, as you asked, the successful examples of global healthcare collaboration. India collaborated, and at one point in time, we even provided hydroxychloroquine to the United States, because at one point in time, hydroxychloroquine was considered to be one drug which would be useful for management of COVID. Then we also had what was known as vaccine Maitri, and the government actually gave vaccines to neighboring countries because they were not manufacturing vaccines, and we had started manufacturing both Covaxin and Covishield in our own country. So that type of collaboration was there. But I think there was more that we needed to do in terms of regional data sharing and trying to really develop a very robust surveillance network, which would actually help in picking up areas where there was a sudden surge in number of cases. Finally, I'd also like to say that we need to develop strategies where we look at how we can improve the healthcare system in general as far as the country is concerned, whether it be primary care, whether it be secondary care, because a lot of health facilities or pandemic care actually sometimes spills over to these areas. So I'll stop there, and then we can have further discussion.
Yeah, thank you so much, sir. So far, what I'm hearing, there is underlying current of I see there is a general feeling that a collaboration across not just the regional collaboration, but also national level collaboration, international collaboration, that is key to improve the healthcare systems across the globe. And my next question is around that point: that what role do international organizations and governments play in fostering the global healthcare system and partnerships and break the silos? You talked about the silos between the labs. Now I'm talking about breaking the silos between the nations, because we all know this is not optional. In global collaboration, international collaboration is key to improve the healthcare system. We all can learn from each other. So let's hear from our experts, all of you, how the different organizations and the governments play a role and can play a role in fostering the collaboration in the global healthcare. So starting with Dr. Soumya Swaminathan, ma'am.
Okay, let me give you a couple of examples of how WHO played a very important coordinating role, and why organizations like that, multilateral, multinational organizations, are very, very important in today's world. We see that there are so many difficult situations around the world that include conflicts, that include a number of outbreaks happening around the world, and that also include climate change, which also is having disproportionate impacts, on the world's poorest and most vulnerable. All of these are things that require global collaboration. No single country is going to be able to handle the situation on their own. So I talked a little bit about the role of WHO in bringing scientists together during COVID to help generate the needed information and to fast track that and convert it into guidelines and recommendations. Another important role was building regulatory agencies together, because as you remember, at the beginning of 2020, we did not know whether we would have even one, let alone several safe and effective vaccines for COVID. So it was very important for the world to come together and agree upon the benchmarks. So, for example, if you got a vaccine with 50% efficacy, would it still pass the benchmark, and so on? So this again requires consultation. It requires people to sit down, scientists to sit together and come up with a feasible and a scientific strategy. So that was done, and that was done very early on, and it was accepted by regulators around the world, including the FDA and the EMA and so on. So there was no confusion about assessing the efficacy and safety of different vaccines that different groups were producing. And the same benchmarks were applied regardless of which country the vaccine was developed in. Another example is, I think, of global collaboration came in the sharing of data. And as we talked about the sharing of genome sequence data, and I think we saw very rapidly that public access databases like GISAID had millions and millions of copies of COVID-19 genome sequence being uploaded practically in real time, by scientists around the world. And that helped the WHO and helped all governments to keep track. Similarly, there are international health regulations which are formulated at the World Health Assembly by member states. They discuss them, they agree upon them. The last update was in 2005 following SARS, and now the international health regulations have again been updated recently, and these lay out the rules for what countries should do when there is an outbreak, a new pathogen which is declared a public health emergency of international concern. What sort of travel restrictions or regulations, what sort of trade restrictions should be or should not be put in place. And we did see during COVID that sometimes countries would react to the news of a new variant and just close borders. And that was not a rational reaction, because even if you closed your borders today on hearing upon a variant, the fact is that virus has already entered your borders, because the virus travels much faster than any of us can track it. And so the WHO kept saying that this is not rational, it's not scientific, and in fact, it's causing a lot of difficulties to people. And countries lost a lot in revenue due to this kind of trade and travel barriers that were imposed upon them. So there are things for which you need to take scientifically based decisions, and you also have to consider what could be some of the repercussions if you make certain decisions. So this is why I think global rules and regulations are important, and they allow certain amount of predictability. They allow a level playing field for all countries. Doesn't matter if you're small or big or rich or poor. You need to be on a level playing field. It prevents unfair practices. A similar role is served by the World Trade Organization, for that matter. So it is very important to have these organizations actually make these rules based on consensus. Of course, all these rules are based on consensus ahead of the emergency. You cannot start making rules after an emergency happens. And so right now, the World Health Organization is convening all the countries to discuss the pandemic treaty. The pandemic treaty is supposed to put in the rules for the next pandemic, whenever that may happen. Hopefully not very soon, but we don't know. And so we have to learn, like Dr. Guleria was saying, how do you learn the lessons from the past? Certain things went well, certain things did not go so well. And how do you make sure that next time we don't repeat the mistakes that we made this time? Let's try and do better than what we did next time. That should be our goal. And for that, again, we need global collaboration. Now, unfortunately, the pandemic treaty is still not agreed upon. It's still being discussed, negotiated. But let's hope that it comes to fruition within the next few months. Thank you.
Thank you, ma'am. Thanks. Dr. Inglesby, would you like to share your thoughts about how the U.S. government is promoting global collaboration and some of the ideas or learnings about, because it is clear that we are all agreeing about the global collaboration. So how the U.S. government is approaching this?
Sure. Great question. I think a couple of high-level observations. First of all, I think it's just in terms of the U.S.-India partnership, I think this is in a very exciting time before we talk about the larger picture. But there's a high-level partnership between the U.S. and India around technology development, which I think which has a lot of promise. It's coming on the base of a huge amount of trade between the two countries. And this new initiative, which is called the U.S.-India Initiative on Critical and Emerging Technology, is really a technology-focused effort, which includes biotechnology and many of the things that we've been talking about already in this panel discussion, and really focused on improving research partnerships between both the U.S. National Science Foundation and the Department of Biotechnology and the Indian government. All that I think is very exciting. And I think it could do, this partnership, for example, perhaps could help support some of the efforts to regionalize in the world more manufacturing of medicines and vaccines. I think all leaders, both in India and the US and elsewhere, have recognized that there is a lot of difficulty in moving products from one country to another. There shouldn't be so much difficulty, but there is, and there's a lot of political challenge. And so the world would be better off if we had regional, at least regional, maybe even beyond that, manufacturing capacities for some of the products that we will rely on in future emergencies. And that's going to require a lot of technology transfer and know-how transfer. So that's one thing that I think is an aspirational goal that I think more and more people are paying attention to. Related to that, I think, is the approval of medicines from one part of the world for another part of the world. The WHO has its pre-qualification process. I think there is some reflection now about how can we move more quickly in some of these efforts while being safe, but also wanting to move products forward in low middle income countries during crises. So I think that's also a goal for international collaboration. We see it now during the response to Mpox in Africa, and the kind of the need to move products there as part of the larger global health response. To the second part of your question, I think is a little bit more about what is the U.S. itself trying to do, specifically examples of global health contributions. I think they could fall into large, kind of big categories, focusing on healthcare system strengthening, disease detection, population and maternal child health, nutrition, and maybe research and development. That's just one way of cutting, different kinds of contributions. And so examples of those kinds of things that the U.S. is working on in partnership with international organizations would be, for example, the U.S. PEPFAR program, which is a program focused on improving HIV care, coordinating that kind of work overseas. That program works closely with the Global Fund to Fight AIDS, Tuberculosis, and Malaria, or also known as the Global Fund. So I think the U.S. is always more successful in its global health programs when it's working with international organizations that are helping to collect international efforts, set standards or priorities, to work with individual countries. The PEPFAR program also works with the UN program on HIV or AIDS, or UNAIDS. And I think, again, more that these national efforts work with international collective organizations, the more successful they'll be, the more useful they'll be to countries. And I think that should be one of our goals. Happy to talk more about other programs, but I think those are just examples of the things that I think are encouraging and are potentially good models for other kinds of efforts.
Thank you, Dr. Inglesby. Professor Guleria, sir, could you please share some of the, what is in general Indian government's approach towards the global collaboration? How does India sees like to help promote the global healthcare? Because as you all would concur that it's not that just the world can help India. It's India can help the world in a quite a substantial way. So could you please share some of the approach and examples about that?
So I think there is a lot that can be done in terms of collaboration, and India can play a major role. India is the so-called pharmacy of the world, both in terms of drug manufacturing and as far as vaccines are concerned. And the capacity to produce vaccines in India is huge, and so is the capacity to produce drugs. So I think there is a need from that point of view, to be able to upscale our manufacturing when there is a need, and share it in terms of global and international collaboration, whether it be the vaccine, which was done partly during the COVID-19, like I mentioned, and also looking at other equipment which can be manufactured when there is a need and can be exported, because that capacity does exist as far as India is concerned. But also I feel there is a need for not only India, but globally, to look at issues one of the issues which came up during the pandemic was as far as patents were concerned, vaccine patents, and whether you could really have a waiver on that would allow countries like India to be able to manufacture vaccines more rapidly without restrictions as far as patent was concerned. And I think that was something which was addressed during the pandemic, even by the WHO. The other important issue is, I think, very aggressive surveillance, which is not only at a national level, but also at a regional and international level, where you could have surveillance with good data sharing. So that type of a network can be made from India as far as Southeast Asia is concerned, and develop a very good surveillance platform, which looks for not only new variants of COVID-19, but for the emergence of any new outbreak which may happen because of any new viral infections, any novel viral, which may have a potential. We have a lot of concern right now about H5N1. So things like that, which could be picked up, and then a containment strategy could be developed, which could be regional and then could also be in collaboration with with international partners. That I think is very, very important, and there has to be a lot of trust and data sharing, because one of the issues that happened was the infodemic. During the pandemic, we had a lot of misinformation through social media, and this created a lot of, I would say, mistrust and problems as far as general public was concerned. And therefore, there needs to be a strategy where we can counteract that in a very scientific and robust manner. And here there has to be collaboration, so that information is sort of scientifically based, is passed on rapidly. And that is another thing which one needs to keep in mind, because this was also something that needs to have good collaboration, so that there is no sort of misinformation. And this led to a lot of issues, even in terms of vaccine hesitancy, because one kept hearing about things happening in Europe, about clotting happening and people dying, which was more of creating a panic reaction from the vaccine point of view. So I think that type of data sharing also is important when we look at how we can move forward in terms of international collaboration.
Thank you, sir. Thank you, sir. Now I'm turning towards another very hot topic in the healthcare field, healthcare technology. So, how can we leverage the technology to improve the healthcare systems and collaboration among healthcare professionals worldwide? So today, this is one example of how we can collaborate. Two of us are sitting in US, two are sitting in India, we are talking. So this is a boon from the technology. This can be extrapolated, this can be expanded significantly. There are examples of telemedicine, telementoring, right? And so let's hear from all of you, like how we can leverage the technology, starting with Soumya Swaminathan, ma'am.
Yeah, so I'd like to give you 3 examples of technology that was really put to very good use during the pandemic and that continues to serve us now. The first one is the digital technology that you just spoke about. It enables us all to get together from different parts of the world, and that just exploded during the pandemic. And we all learned very quickly to get used to this new way of communicating. And in fact, what it's done, it's democratized knowledge transfer, because it is much easier for a person to get on a Zoom call than to travel hundreds of miles to go to a conference. And so I think this has been a very good thing. And one example of how this is being used is something called Project Echo that I serve on the board of, and which has actually, had this massive impact really on training and capacity building of healthcare workers, both in India and the US, as well as in other parts of the world. And essentially what it does is, if you're an expert in one field, there's a limit to how many people you can teach in a classroom. But if through digital, you are able to reach out to hundreds of people located geographically very distant places and build their capacity, then, I think that's an incredible way of improving healthcare outcomes. Okay, so using the platform, I think you can have many innovations like Project Echo that do that. The second innovation or technology I would like to talk about is the mRNA platform that was, again, for the first time, successfully used during COVID, though it's been under development for a very, very long time. And vaccines were being developed for many other diseases. But very rapidly, we were able to see, the Moderna and the BioNTech vaccine, of course, that came out, but subsequently also an Indian mRNA vaccine from Genova that has also been shown to be extremely safe and effective. And therefore, this mRNA platform enables us to now develop many more vaccines, but beyond vaccines, monoclonal antibodies and therapeutics for many diseases. So it's opened up a whole new area where this technology can be used to help healthcare. But I want to come back to a point that Dr. Guleria made earlier about sharing of, during the pandemic, these companies, Moderna as well as BioNTech, Pfizer, refused to share their mRNA technology. If they had shared it, as soon as they had found their vaccine to be successful, companies in India and other countries could have started manufacturing these vaccines. And in 2021, we may not have faced such a severe shortage of vaccine doses as we faced, and which then, of course, led to loss of lives. So side by side with new technologies must come the agreement to share and to build capacity around the world. Africa as a continent, of course, suffered particularly badly. And the third example is the digital vaccination certificates and the whole digital platform that India in particular harnessed for delivering the vaccines. It was called the CoWIN platform, and everybody had it on their mobile phones. And you could make an appointment, you could go to your nearest center, you could get your vaccine, and you got your digital certificate, which was absolutely easy, interoperable. And so WHO at that time also developed the standards for interoperability of digital vaccine certificates. So again, when you have international standards, it becomes much easier for countries then to put it in that format, so that even if you're going across borders to another country, your digital vaccine certificate is still valid. And so I think we did it for COVID. We should probably do it for all immunizations in the future. But it was surprising that many high-income countries were still giving certificates on paper, whereas India, right from the beginning, had a digital vaccine certificate. Thank you.
That was a very good example. I do have the paper certificate here in US with me. So Dr. Inglesby, would you like to touch upon this topic on how the technology can be leveraged in the healthcare?
Sure, yeah. Just to add to that great list that Soumya just presented, I think some of the other technologies that came to the front during the pandemic, which I think will now help maybe change other ways we approach infectious disease on a more regular basis, would be diagnostics, which have already been raised here, but the idea of pushing diagnostics out further away from clinics to in the hands of people who are actually sick, rapid diagnostics at really low cost, I think is a huge innovation that could help around the world if we're able to move them from the high income countries to more of the countries that could use them outside of official clinical settings. The second category of technologies, which I think were shown to be so important and yet so vulnerable to disruptions in pandemic, were personal protective equipment, particularly respirators. In the U.S., we're now thinking a lot more about reusable respirators in the healthcare system that don't have to be thrown away after single use. A reusable respirator here, depending on the technology, you might be able to use 100 times, 200 times, as opposed to a single-use respirator, which goes in the garbage often and contributes to massive global supply chain problems. So really focusing on potentially things that are sustainable, more resilient. I would put indoor air quality and indoor air technologies maybe in that category as well, as a system that reduces the risks of people who are inside buildings of catching infectious diseases from each other. That's beginning to be, or started to be, a focus during pandemics, during the pandemic response here in the US, and I know in other countries as well. And then finally, I think AI tools will also begin to push some technologies further out into the field. So diagnostic technologies perhaps could be augmented by AI. I don't know that we're not exactly there. I don't think large language models themselves have substantially changed the practice of I mean, they're beginning to in certain ways more in the medical record realm, but in terms of being able to extend that to population health. I also am very impressed by India's efforts to try and make some medical technology that are very expensive more affordable, such as I saw a big MRI project where a large Indian company is working on making a much more affordable MRI, which could be useful around the world. So I think India really should be commended for its efforts, not only as the pharmacy for the world, but also as the innovator around other medical technologies that could be used much more broadly than they are now.
Yeah, thank you so much, Dr. Inglesby. Dr. Guleria, sir, would you like to share your thoughts around technology integration in the healthcare? And I know, I don't want to steal the thunder, but I know that you are quite conscious about the cost effectiveness of these technologies. So maybe you can share your views on that. Thank you, sir.
That technology has been able to do now have been covered. But I think in India, what has happened is two or three things. One was, as Soumya mentioned, we were able to use technology in the pandemic not only to monitor people could get their vaccine, but the whole supply chain of vaccine could be monitored through the technology that was available through the CoWIN platform. So right from the manufacturing plant to the transport using maintaining the cold chain to various parts of the country, and also then using drones to deliver vaccine to remote areas was something that was possible in India because of the use of technology. But I think the other major thing, besides the fact that there were so many webinars, and the All India Institute of Medical Sciences at that time was almost every day holding webinars, we were also conducting what was known as e-ICUs. So supporting ICUs in different parts of the country and talking to doctors there in terms of management of cases of COVID-19 as the pandemic evolved and as science evolved. We started off with a lot of drugs which we were not aware of, and we were using them. So from ivermectin to hydroxychloroquine, then to remdesivir. So all of these evolved over a period of time, and therefore there was a need to be able to reach out to physicians in different ICUs. And I remember even in one ICU, I talked to the physician there and he said, I'm actually a gynecologist, but I've converted my hospital into a COVID hospital and I'm now managing patients in an ICU setup. So for all of that, I think technology really helped in providing support and to these people in terms of how to manage sick patients and be able to save lives. The other thing that technology did was it really brought into fore the advantage of remote monitoring, either by wearable or non-wearable devices. We had patients who were on home care with COVID-19. All of them had a pulse oximeter. They could monitor the oxygen saturation. They could tell the doctor, this is my oxygen saturation. Should I come to the hospital or can I stay at home? There were people who even did what was known as a 6-minute walk test, made the patients walk for 6 minutes and see what was the fall in oxygen saturation to see whether there was any need to come to hospital. So I think that opened the access to healthcare in a big way. And I think that is the bigger advantage, that you can now look at healthcare being provided to people even in remote areas where health facilities may not be that good, because you could use technology, wearable and non-wearable devices, maybe even AI tools, and be able to reach out to these people in remote areas where healthcare is limited. And I think that is one major thing that happened as far as COVID-19 was concerned. It opened the door. We were still reluctant as far as teleconsultation was concerned, monitoring patients remotely was concerned. But I think that is becoming more and more now common. And even in most hospitals, you have teleconsultations as a common thing. And that really cuts down the cost of healthcare. Patients don't have to travel very far. And it also provides better monitoring in terms of how patients are doing. So I think that is also something that has happened in a big way. As was mentioned, there is also this whole issue of trying to cut down the cost of healthcare. We all know that as medicine has moved from clinical medicine to investigative medicine, the cost of healthcare has become tremendous. And that is sometimes creates a lot of problems, especially patients have to pay out of their pockets. So a lot of frugal innovation came in as far as the pandemic was concerned, trying to innovate to make equipment and devices which are cost effective, and therefore the cost of healthcare may come down. And I think that is where also one area where technology has actually worked a lot as far as providing better healthcare is concerned. So I think these are important issues which I think we learned during the pandemic. I think the webinar and the access that now people have has had its advantages and disadvantages. We were able to reach out to a large number of individuals, but at times it also leads to more misinformation, and therefore we need to be very careful about how we disseminate information, especially when technology is now easily available to the common person. So these are, I think, the advantages that we have as far as technology is concerned. And I think as we move forward, whether it be AI, Internet of Things, big data analysis, technology is going to play a big role as far as future physicians are concerned, not only in India, but across the globe.
Thank you, sir. From my own field of oncology, like when I was treating CML, chronic myeloid leukemia patients at AIMS, the patients had to come from very long off places, sometimes from the other parts of the country, just to show their hemogram, HBTL, CDLC, and platelets, so that I can monitor and I can titrate their dose of hydroxyurea, right? And now this can be done through a device. Like the patient doesn't have to travel thousands of miles just to show the hemogram. They can just do the testing at home with that device, send the results. So your points are very well taken, and that brings me actually to the last question of this panel. In what ways public-private partnership can contribute to global healthcare collaboration? We are talking about collaboration so far between the governments and the healthcare system. Now we are talking about the public-private partnership. So, Soumya ma'am, do you want to share some of your experiences or vision about this?
So I think public-private partnerships are critical because there are things government can do which private sector can't do, and vice versa. So government essentially invests in high-risk research because the kind of investments, like the US makes, for example, in basic science through the National Institutes of Health, leads to a huge amount of innovation and discovery, which then translates into products. So this happens, of course, around the world. The volume of government investment could vary from country to country, but essentially countries are the ones who really will need to invest in basic as well as in translational research. What companies are good at doing is making a product, and they have to make it reliably and of good quality, and it has to be every batch has to be as good as the previous one, and so on. So they have to assure quality. They have to then, it's a health technology, it has to be safe, it has to be effective, it has to meet the standards, and ideally it has to be affordable as well, and it has to be easy to use, etc., etc. So when these two come together, then of course you can do a great deal. And that's what happened during COVID. Many countries actually went into public-private partnerships where governments actually gave money both for research, but especially for development and for manufacturing. And the companies, in turn, many of them set up additional facilities, or they reprogram some of their existing facilities so that they could focus on developing COVID-related products. So I think it's absolutely key for the future, and I think what will be very good is to develop these good models of public-private partnership where public health needs are being met, are being addressed, and that the private sector is, of course, will have to look at profits and so on, but at the same time, they should also be the public health goal, and therefore working together, I think that can be achieved where either one alone may not be able to really achieve it.
Thank you, ma'am. Dr. Inglesby, do you want to share your vision and experiences of each?
Yeah, just briefly, I completely agree that the private sector is critical in strengthening, providing basic healthcare in emergencies. In the U.S., we could not do that work at all without the private sector, and there is a fairly strong partnership between the government and the private sector in the healthcare space. It doesn't always work perfectly efficiently, and yes, there are problems with profit and gaps, but it is still a key player. I would say one example of how important the private sector is just to look at India's private sector contributions to improving U.S. health, like that as one example on the axes. And from a recent study I saw, Indian pharmaceutical companies supply 4 out of 10 prescriptions filled in the U.S., 47% of all generic prescriptions filled in the U.S., and out of our top 10 therapy areas in the U.S. by volume, Indian companies supply more than half of prescriptions. So it just shows how important the private sector in India is, even in the U.S., let alone how important it is for India. And thinking about India's contributions and U.S. contributions to global health, the private sector, as I think Randeep said, 60% of the world's vaccines come from India, more than 170 countries. In the last 8 years, more than 4,300 research studies occurred in India in the realm of health, funded by not only Indian government, but also other governments, just showing how critical the interaction between researchers and governments are in the science world. And India, in its leadership of the G20 summit, focused on One Health. So again, bringing together both organizations that work on health in the private sector, governments that work on health. So I think there's just lots of examples of the close interaction with government and private sector. And I'll leave you with a final example from last year between U.S. and India, both partnering together to bring healthcare expertise to a third country. This was a trilateral partnership with the Republic of Fiji, focused on telemedicine, psychosocial healthcare, emergency care during disasters. I think that was just a great pilot example of the two countries bringing some of their expertise together in an effort to help a third country. So thank you, and I'll stop there. Really appreciate the last hour of discussion.
Thank you, Dr. Inglesby. Dr. Guleria, sir, do you want to share your thoughts around public-private partnership?
For science and medicine to progress forward, each has their own advantages, and that needs to be harnessed so that it can really be useful for patient care. If you look at research itself, a lot of research is done mainly by institutes which are funded by the government. But once a molecule is developed or a point of care test is developed, it has to go to the private industry to take it forward in terms of manufacturing, in terms of investment, in terms of how they can then do all the quality tests. So there has to be collaboration, and I feel that is something that we need to move aggressively in our country, more collaboration between institutes which are doing science, and then how they can then work with partners in the industry to take it forward. There is a good program, VIRAC program, which the Indian government has, which tries to promote that. But I think a lot needs to be done because this is crucial as far as taking research forward is concerned. As far as clinical medicine is concerned, the public sector is more involved when it comes to preventive health measures, surveillance, screening, and other things. But when we start looking at patient care point of view, it has to be a partnership where there is involvement of not only the government sector but also the private sector in terms of providing good degree of patient care, both in secondary, in tertiary towns, but also in primary, secondary, and tertiary care. So I think if there is collaboration, both in terms of private and public sector, both in the research arena, both in the manufacturing arena, and also in patient care, there can really be a lot of good and a win-win situations for both sides. We need to really move out of our silos and develop strategies where there can be more aggressive public-private partnership, not only within the country, but as Tom mentioned, between different countries, because that will really help in the long run.
Yeah, thank you so much, sir. Maybe I'll take 1 minute just to highlight how the Princeton Foundation executed the concept of public-private partnership during the COVID. During the second wave of COVID in India, which was kind of unanticipated to a certain extent, it was ravaging the whole country. And within the span of just 2 weeks, Princeton Foundation was able to raise medical supplies worth several $1 million in US. Harvard was our biggest donor, and Maersk Shipping Corporation, they provided free international transportation for all these medical supplies to India. And in India, we worked with the Ministry of External Affairs and Niti Aayog to for further distribution in India. So this was a prime example of public-private partnership where the institutions like Harvard, companies like Maersk, foundations like Princeton Foundation and Government of India, they work together and in a very efficient way. So yes, I do hear that public-private partnership is key for the delivery of the community. So with that, I would thank you all for your sparing your very, very valuable time despite your busy schedule. I think the key message here is that collaboration across the countries, across the nations, across the labs, across the clinicians, academicians, that is key to improve the healthcare systems, not only for the emergency, but also for the delivery of the healthcare in general. So with that, thank you so much for your time. Thank you. I really appreciate. And we will send you the recordings later on. Thank you. Great day.